this document. It's very important because based on this document, we can look and try to improve these meetings. So your feedback is very, very necessary. We would like to also ask if there is a lecture that has not been included in the program that looks at the nutrition. We wanted to ask you if you would be interested in hearing that lecture additionally from the ones that have been put on that schedule. We can adjust the time so that you leave here just the way you would leave at the end of it. It's not going to add more time, but it's related to nutrition, and we felt that nutrition was a topic that was very important to what we need to discuss with the extremely premature babies. So if it is okay with you, we will do a little bit of tightening of our schedule and try to fit this nutrition presentation, if you agree. Agree? Okay. So today we're going to talk about, the first talk is going to be a topic that's not controversial. We need non-controversial topics. And so you can see that I started by saying when and how should we close the ductus. And then there are many people now that are saying we should not be closing the ductus. So just the title makes it very controversial. But I was very interested in this topic because of some work that I had done in the past when I worked at the University of Miami in 1990 with Dr. Eduardo Bancalari. That's when I started to do clinical research. And before that, my time, the ductus for me was a big issue because at the time when I started to rotate through a neonatal intensive care unit in 1982, 1983, we were, as residents, we learned a lot about misdiagnosis. And so at that point in time, anything that, any baby, premature baby that had metabolic acidosis, we said this baby is infected. And we would treat the babies with antibiotics. And at that time, we did not have echocardiograms in Colombia in our hospital there. And we did not have cardiologists that were trained to do echocardiograms either. And so everything that we did was clinical. And it was that time that if a baby needed a transfusion, they would call the resident, they would call us, and we would put our arms, and they would take the blood out and pass it to the baby if you were O negative. So that's the time that I began to have that relationship with the ductus, and it was pretty bad because I did see a lot of babies die with ductuses. And we had cases where our babies, we had treated them for sepsis, and they died, and they had the pathology correlation, and then they showed us, all blood cultures were negative, no evidence of infection, but in the pathology they would show a huge ductus. And so what we thought was sepsis was really a ductus. Today, in 2012, very little babies die from ductuses like we used to see them there. And so when all this controversy started about ligating or not the ductus, I thought it's necessary to go back and recapitulate what was going on in the past and what we were doing here. And so, again, there's a concept here, let's see, that here. It's very important. We've talked about basic concepts in looking critically at the literature, but I think that there's also something that we should notice about our nature as human beings. We tend to like the extremes. We like the extremes because it makes us feel comfortable if we're on one side or on the other side of the extremes, but it gives us some confidence that we know what we're doing. So we tend to move and gravitate more to these extremes. And when we take opinions with respect to management of our patients, we tend to go more to these ends. It's very hard to be able to take evidence from both extremes and get down into the middle where there is balance. But to be able to do that, of course, you have to question yourself first if you are biased or not biased. And some people look at the word biased and they say, oh, that's a bad thing to be biased. I don't think it's a bad thing to be biased if your bias is based on objective and good evidence. Then you need to be biased. Yes, that's when we talk about losing equipoise. You can lose equipoise, but if it's based on good evidence. But if it's not, and then of course these positions on the extremes, some people have said the extremes are always half truths. And so somewhere the reality is here, but what a difficult place to be here. And the PDA surely denotes that. There's another trend that we have, and when we are taking care of babies and we're in neonatal intensive care units, we have to look at something that's called, policies. And in some of the hospitals where I work, the policies are like military rules, that if you break the rule, you get killed, because they say this is what we do here, and this is the policy, and if you ask why is it the policy, and everybody starts to get nervous. Well, the reality is that there's also our human tendency to want to have just one policy to simplify the process. And that's not bad. That's a good idea. But when you're talking about human beings and patients, just one policy is like saying, one shoe fits all. And that's where the problem is. We have nurse practitioners that are nurses that are trained just to take care of babies and to be in the resuscitation room, and they are excellent at what they do. But they want policy, and they would like to have one shoe fit everything for all the babies, so that they can just look at a baby and classify the baby, look at the weight, and then say, this is what I'm going to do for the baby, this, and this. And that gives consistency, which is important. It does improve when you're consistent, at least. Even if you're wrong, you're consistently wrong. If you're right, you're consistently right. But consistency is also part of what our nature is. And that when we have babies, the problem is that babies don't follow these rules that we want to create as adults, and we want to put them into that one shoe. But the babies are not like that. Each baby is an individual. And so this is part of that presentation. So medicine, from that perspective, is both a science and an art. And every newborn is an individual with his or her own set of individual characteristics. And so this is where I put this part of it. Yes, we have science and the physiology, which is something that we recommend all our residents. We really want them to teach them the physiology, because memory betrays you. And when you're in front of a baby that doesn't behave like the usual babies, the physiology helps you to individualize that baby. But at the same time, medicine is an art, because that balance. Now we all agree, I think, after this meeting, that a double-edged sword cuts both ways, and you're going to bleed both ways. But the art of our medicine is which you have to pick the one that bleeds the less. And how do you do that? But you have to accept that there's going to be morbidity on both sides of that sword. And so that makes what we do an art. And so the goals of this presentation is to look at the evidence that we have with respect to the ductus and determine if we have equipoise or if we are biased in one way or another with respect to the way we manage these babies. Try to rationalize the individual management of babies with a PDA. Again, this is part of that art that we're talking in medicine. And what I'd like to come out of this is for all of you to start imagining if we needed to now, today, 2012, do a randomized control trial to test whether we should be closing, how we should be closing the ductus, how would we design this type of trial today? That would be the most important goal, if we can get there, because that's one of the questions that people are not willing to ask at this point in time. Everybody is complaining, and everybody is saying there's no evidence. But nobody has, at this point, said, no, this is what we really have to do, and this would be the best design for a study in 2012 to look at the PDA and what we should do with this. And so we have a lot of very intelligent people and minds here. We would like to try to get to that. point, and we will put that at the end. But as a background, we know that the PDA is one of the most common cardiac condition among preterm infants. PDA affects approximately 40 to 55% of the preterm population. Infants born at less than 28 weeks or less than 1,500 grams at birth. Preterm infants less than 30 weeks gestation with severe RDS have 65% incidence of persistent patent ductus arteriosus that can go beyond the 4th day of life. To this, when we talk about this type of information, again, it's important for us to locate ourselves where we are. We're in the post-prenatal steroid era and post-surfactant era. A lot of the research, I would say all of it, that was done, all the randomized control trials were before surfactant and were before the use of prenatal steroids. And so it's a different type of populations. And it's all the discussions that are occurring today somehow do not take that into account. We have a different type of population of babies, and we've made emphasis on that. This is a recent paper by Dr. Kleiman, who's been doing a lot of research with ductus, Ronald Kleiman. And these are rates of spontaneous ductal closures, and he has them in percentages: closed on day 4, closed on day 7, closed at discharge. Where you see NA, 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 that means that it's not applicable, it's that there's no information at all. So nobody can say anything. So those are missing pieces of information. So that just tells you we need to do research to try to look at that. But that's never been answered. And so you see a full-term baby closed on day 4, almost 100%. We know that by 72 hours, almost 85% of those ductus are closed. By 4 days, 100%. Closed on day 7. Greater than 30 weeks, they have 90%. 27 to 28 weeks on day 4, 22. Closed on day 7, 36. And you can see that it starts decreasing as your gestational age goes down. When the majority of the papers were done and the studies were done in the randomized control trials with the PDA, we weren't taking care of these babies down here. We were talking about babies that were 32, 33, 34 weeks. And so we have to take that information with a grain of salt, but this is a very different situation. And now we're taking care of babies that are 24 weeks. And you can see that closed on day 7, only 13%. And what happens down here? We don't know that, but we think that, yes, they most likely will still be open, some at discharge at a higher rate than all the previous more mature babies. And this is classified in weights, which a lot of us use when we do our research, where they are saying that between 1,000 and 1,500 grams, 35% close on day 4, 67% on day 7, 21% for less than 1,000 grams, and closed on day 7, only 34%. So a large percentage of babies with ductus is open still on day 7. And so the question was, okay, ductuses, yes, it's part of the normal physiology. We understand it. We understand what happens in fetal life. And then when a fetus comes out into the extrauterine environment and has a process of adaptation, we know that the pulmonary vascular resistance is elevated and the ductus can be open, and that exposure to oxygen, all that, we understand that physiology. And in general, we really are not concerned about the ductus unless the ductus comes out to be hemodynamically significant. And there's a lot of definitions for what people say is hemodynamically significant. This is just one of them. Large left to right shunt to systemic blood flow with subsequent pulmonary over circulation and the diastolic seal. And we're all very concerned about the effect of that diastolic field, but of course we're very concerned about what happens to the lungs. And as a background also to this, we have that PDA remains hemodynamically significant in preterm infants due to decreased ductal sensitivity. The things that we have mentioned: increased circulating prostaglandin E2s, and increased ductal tissue sensitivity to E2, nitric oxide, and decrease, of course, in pulmonary vascular resistance. But what are the effects of having a hemodynamically significant PDA, and we all agree that we're concerned about overflow of blood to the lungs. And babies, we've noticed that even babies on day one who are born with severe respiratory distress, some of those babies can have suddenly pulmonary hemorrhage and go into pulmonary edema and require a significant amount of support. All these are the acute part of that. Long term, of course, we're concerned about bronchopulmonary dysplasia. We're concerned about intestinal ischemia, and we've learned a lot about that with our cardiac patients that are now more premature. And so we have to keep these babies with their ducts open for a long time while they grow and they go to surgery. We just reviewed at Wake Forest University morbidity on those babies that we had on prostaglandins for a long time, prostaglandins. And there is a strikingly high incidence of necrotizing enterocolitis in those patients. And I'm talking about babies that you keep for 4 weeks, 8 weeks with the ductus open. And our cardiologists didn't understand that. They just told us, you the neonatologist, have them grow, bring them to our, and we'll operate them when they're, 2.5 kilos, whatever. But what we were seeing is that these babies were not getting to that point in time. We had a lot of difficulty growing, but on top of that, the morbidity that was happening, and when we went and reviewed the literature and all the cases that we've had in like 5 years, necrotizing enterocolitis came out as one of the major causes why these babies were dying before they got their cardiac surgery. So we do believe that this is serious, that this is just not something that some people have perceived. And of course, you have these other aspects that need to be researched more, but they talk about reduced middle cerebral artery flow velocity and decreased superior vena cava flow with concurrent increased risk of intraventricular hemorrhage. That is something that is there, but I think the evidence is much weaker in that area. And of course, death, we've seen it. I've seen it. I think all of you have seen it. Our younger trainees have not seen it, and so they tend to think that the PDA is something that is not significant, that's something you can deal with without having any problems. So then comes the treatment modalities for this, and so you have, these are the treatment modalities: fluid restriction, diuretics, and inotropes, and this was a treatment that was used in the past a lot. PDA ligation, early or late, prostaglandin inhibitors, indomethacin, ibuprofen, and what people are now, we're talking about our prophylactic plus the rescue indomethacin, which is a treatment that we never planned. We were concerned about intraventricular hemorrhage, and we had the studies with the prophylactic indomethacin, but we didn't ever consider that we were going to add 7 days or 5 days of indomethacin. There are cases where you give the 3 prophylactic doses and then suddenly the ductus opens, and so on the next day you're giving the 4th, the 5th, the 6th dose, and then you have people repeating courses. And suddenly you have a child with 8 doses or 9 doses of indomethacin and you have bowel perforation. We had just a month ago a case like that, exactly like that. And so the baby developed bowel perforation and developed NAG after the 7th dose of indomethacin. And there were studies in the past where they looked at 3 doses versus 5 doses, which was considered a prolonged treatment, and saying that you could decrease you could increase your success rate for closing the ductus. That's an old study, but as we increase the doses, we also start to see an increase in morbidity. Again, the same concept of the double-edged sword. And so this was a very interesting paper, because this paper came out in 2004, and current opinion in pediatrics. And so now you understand what when I become nervous with the word opinion, yes, and now you have a whole journal that's called Opinion. And for me, it's difficult to read the journal, it's important to read the opinions. But what concerns me is what happens with the opinions. And so this is we'll go through the summary of the opinion that was set forth. And these are good colleagues of mine that I worked when I was at the University of Miami. And so I know I've worked with them in the past, but this was stated like this: given the current lack of evidence of benefit from closure of the PDA, even a symptomatic PDA, and in consideration of the potential for significant harm from therapies used to close the PDA, these therapies should not be considered a standard of care. And we've talked about the word standard of care, yes. And I think that, yes, in something that's so uncertain, standards of care is a very concerning statement, of course. An acceptable alternative to routine closure of the PDA in any way with surgery or with medication, they're stating here, would be to avoid fluid overload and observe for signs of left ventricular failure. And so when this paper came out, we start to see a change in the way we practiced medicine and with respect to how we treat the PDA throughout the United States. And it happened in all our units. And we start to see that babies that were extremely premature babies that were having ductuses were staying on ventilators longer or on jet ventilation for 60 days with the ductuses open. And many of those babies were going to surgery when they were 35, 40 days, 50 days of age with severe chronic lung disease, and then going to surgery and coming back in very, very bad conditions. And then we would not see any benefit from the PDA ligation. And so it moved the pendulum from a point where maybe we were doing too many PDA ligations and it was a concern, and we were on one side of that pendulum, maybe babies getting exposed to an intervention that they did not need, to the other extreme of not doing anything to these babies. And in the institutions that I worked these past 10 years, these two institutions, the same situation. We were seeing babies, and we were questioning why were we letting these babies stay with their ductuses open so long. And so this paper was written in 2012 in Journal of Perinatalology. And they talked about prolonged persistent patent ductus arteriosus, potential perdurable anomalies in premature infants. And so what they did was a case-control study. And many people will say, well, this is a retrospective study, this is not good. But if you look at this paper, it was a prospective study. They collected data prospectively. They took babies less than 1,000 grams who had a PDA, and they divided them into groups. Those that they called prolonged persistent, which were babies that had those ductuses more than 3 weeks, and a control group where you could have a ductus, but it was less than that period of time. And so they compared those groups to see what happened over time with different variables, and they found that this prolonged persistent PDA greater than 3 weeks was associated with a significant increase in the number of days on mechanical ventilation, oxygen treatment, length of hospital stay, and in rates of BPD, 60 versus 4.5%, NEC 29 versus 5%, ROP 43 versus 5%, direct hyperbilirubinemia 41 versus 3%, and so on as you read that, more trachs, and morbidity was higher. And so when I read this paper, I said, well, I went back to 1989, 1990 when I was doing that project that I'll show you about, but still something that should raise a flag. Again, you're establishing associations and not causations when you do these types of studies, and you have to understand the limitations. But when you have these associations, and they're pretty strong associations, you really, because this is morbidity, you really need to look at this very, very carefully before saying, dictating a plan for management. So we have to go to the past right now to try to understand what we're doing right now. So I'm going to take you back in time, and we're going to go to 1966, when this paper by Dr. Auld was published in Journal of Pediatrics. And he talked, the paper, Delayed Closure of the Ductus Arteriosus. He presented 7 cases. And you can see the weights of these babies, all above 1,000 grams except this baby. And these gestational ages, the majority were above 28 weeks. All of them had respiratory distress syndrome. And this just looks very difficult to read here. So that's this column here where you have the numbers over here is PDA day of diagnosis. So it was the day that they said this baby has a PDA. And that was basically, clinically was done by just auscultation and saying there's a murmur here. And then these were the ones that had congestive heart failure. So all these babies were diagnosed with congestive heart failure except this baby here, number 2. And these were the days of the ductus stayed open, yes. And these were the times, the months that they were followed up. And what they were able to see here, that this baby had the ductus open for 15 days, this one for 39, 47, 30, 40, this one only 3. And they were followed all up at 7, 18, all these months. All these babies did well. None of these babies got a ligation. All those patients were treated conservatively with that restriction of fluids. Some of them got digoxin because they were in congestive heart failure, the ones that had the positives, but just symptomatic management, and they did well. But again, these were bigger babies and not the type of babies that we would be managing today. So they concluded spontaneous closure of the ductus arteriosus may be delayed for several weeks and can occur even when severe congestive heart failure is present. Surgery should be delayed as long as possible in anticipation of spontaneous closure. So what was said in 1966, yes, is what they were saying in that article that I just presented to you, and giving the same opinion. So it was not novel information from that perspective. But what was different from that perspective is that the type of patients that they were managing in 1966 were different than the type of patients that we're managing in 2000. The other article was like 2004. Patent ductus, this is another study by Neil. Patent ductus arteriosus, complicated respiratory distress syndrome. This is 1975. And their conclusions, and I went into detail to see what is it that they had, how they had rationalized the treatment and what they were proposing. They stated PDA is more frequent in the infant with RDS than in unaffected. We have learned that, we agree with that. In neonates without RDS, diagnosis of a hemodynamically significant PDA is not difficult and treatment is non-controversial. And so for them it wasn't controversial at all at that time for this group of babies. For them the difficulty was the babies who had RDS, because they divided the ductuses, and they were, a whole group of researchers at that time found out that if you had RDS, yes, and you were recovering from RDS and getting open, getting better, it was at that point in time that the ductus opened up. And so they knew that that was the ductus. And so they didn't have any controversy with respect to that. And for them, that was a PDA, and they could treat it, and not a problem. The problem was when the baby was in the middle of having RDS, and then they couldn't really tell if it was the RDS or the ductus. It was in the middle of the acute period of the disease. So they classified it as 2 different entities. The infant with a PDA but without congestive heart failure is observed. That's what they're managing. If congestive heart failure appears, medical management is instituted, and if unsuccessful, then PDA ligation. If the infant has RDS, PDA may be difficult to diagnose, and the indications for surgical intervention are not clearly identified. So from the results of their study, they found that out of 396 babies with RDS, 76 patients had a PDA, 19% in that population that they looked at. A larger population, a more mature population of babies, 19%. So it's different from the data that I showed you initially. Of those 76 babies with PDA, 20 had a continuous murmur. And it's very interesting, you read that literature, and they do studies where if they just found a systolic murmur, yes, they considered that benign, they didn't intervene. When they had a continuous murmur, that was equal to congestive heart failure, and they were able to demonstrate that those babies were the ones that benefit more for more aggressive treatment. But 14%, 50% of those 28 that had a continuous murmur developed congestive heart failure. And 1 out of 48 with systolic murmurs developed congestive heart failure, only 2%. So if you just had a systolic murmur, the likelihood you were going to have congestive heart failure was not good. And then you had 14 out of 15 infants with congestive heart failure had severe RDS. So they said, yes, the more severe your RDS, of course, then your PDA is going to be more significant. And here they show, they took 10 of all the babies that they studied from this trial, there's just a section of them, And you can see the weights of these babies, all above 1,000 grams, bigger babies. And this is the day they diagnosed, the duration of how the PDA was open, and then you show them all spontaneous closure. And they just had one case that developed sepsis, died. Another baby had neck and died. And then this baby, who was with the ductus open for 40 days, died of respiratory failure from BPD. But the idea that spontaneous closure did occur in this population was pretty clear. So we do know that some of the ductuses, even if they are prolonged and they're open for a long time, will close spontaneously. And I think that there's no argument to that. That pretty much shows it. And then they looked at a cohort of surgical management of PDAs. They had 5 babies in this group, and they basically show there that, well, those are the birth weights, and then you have age of the onset of the murmur, age of the onset of congestive heart failure here, and then age at surgery. So one got operated at 28 days, others at 56, 112, 35, 21. It almost seems the same as what we're doing right now, because that's what's happening in our units right now with people letting those ductuses stage. You have a lot of variability in the duration of that. So summary and conclusions, the incidence of PDA in infants recovering from RDS is higher than in premature infants with without RDS. The direction and magnitude of flow through the PDA depends on size of the PDA and the relationship of pulmonary to systemic resistance. We all agree. A characteristic murmur was not detected prior to 4 days of age, and congestive heart failure did not occur prior to 10 days of age. Well, here they were learning that in many cases when they looked at their autopsies, there were a lot of babies that they did not diagnose with having a PDA, that when they did the autopsy they found that the PDA was very large. And so then their diagnosis of a PDA could not solely be based on auscultation. And that was an important finding. Still today we have a lot of people going around, we all go around to see if the baby has a heart murmur, yes or no, to say if maybe the baby has a PDA or not. But if you have a baby that's very, very sick on a ventilator and respiratory failure that looks like had pulmonary edema but doesn't have a murmur, that doesn't tell you that the baby doesn't have a wide open PDA. So that was an important finding, and this is basically tells about those autopsies that they looked at. And then we have this interesting study now, 1975, another by Thibault, a group where he divided RDS into severe and mild. And you can see they have PDA and ligated, PDA not ligated, for the mild to moderate, PDA ligated, PDA not ligated, and no PDA demonstrated by aortogram. That's what they did at that time for this study, aortogram. And it's very interesting how they did it. I'll show you that technique. But this is the weights of the babies, all except this group here of 14 were less than 1,000 grams. The rest were above 1,000 grams. And in that second column, the gestational ages of the babies, they were all above 28 weeks gestation. And congestive heart failure for this group, these two groups were at 2.5 days. Very early on, they developed congestive heart failure in severe RDS. And for the ones with mild to moderate, it was on average 10 to 11 days, so it was happening later. And that's a very interesting and very important clinical observation. Then you have that last column that is talking to you about when they were ligated at 8 days, and these were ligated later at 15 days. And then they talk about survival. And you can see that there were 5 babies that lived in this category, 2 died. Of the babies that had severe RDS, that had a PDA that was not ligated, no survivors. They all died. And so that sort of information made them understand, yes, if you had severe RDS and you had a ductus, it was better to ligate than to not ligate those babies. That was the impression that they had. When you had the mild to moderate, it all changed because the survivals didn't really make a difference at this with a mild to moderate RDS. So again, a very interesting observation. And look at the aortograms that they did. So what they did, they put a catheter through the umbilical artery and put it all the way up into the ascending aorta. And then they injected the contrast. And so this one basically shows a very nice aorta, but you can't see the pulmonary arteries here. And so the ductus was not an issue in this patient. This one, yes, is already showing the pulmonary artery. So this has ductal shunting, yes, and it could be bidirectional at that point in time, but they were saying there was some, that there was shunting through the ductus because you were seeing filling of the pulmonary arteries. And then this one was the one with congestive heart failure. So what was happening with this aortogram was that all the contrast was going into the pulmonaries, to the lungs, because all the flow was left to right. And very little contrast was going down the aorta. There was aortic seal. So you can imagine if you have now a symptomatic baby, yes, and you do an echo and you see this wide, large ductus with all left to right shunt. Well, this is graphically what could be happening to that baby. And that's the excessive flow to the lungs that we're always talking about, that we're concerning, that the baby that could then suddenly go into pulmonary edema or have a pulmonary hemorrhage. So the key thing is, how could you make that diagnosis without doing an aortogram, which of course had its complications and there were problems with techniques. So it didn't become a very popular way of doing it, but it did teach us something very interesting about how ductal flow moves. So conclusions from this is that the absence of a heart murmur does not necessarily exclude possibility of a large ductus. Preterm infants surviving RDAs may develop clinical signs of a PDA with or without heart failure, yes. The lack of clear-cut objective criteria for the diagnosis of persistent heart failure has made the indications for the surgical ligation of PDA uncertain. And you look at this, written in 1975, and you say, oh my gosh, we're still thinking about this. This is the big question that we still cannot answer. But it was relevant at that time. Severity of RDS was associated with clearly development of severe congestive heart failure. So the severity of the disease is something that we still should be considering as important when we're trying to make decisions and individualize the care of our babies. So again, trying to have one shoe that fits all for management of these babies, it depends on what is the situation for each baby and how premature. This was the first randomized control trial out of Vanderbilt, my previous institution where I worked with Dr. Cotton and Dr. Mildred Stallman. Randomized trial of early closure of symptomatic patent ductus arteriosus in small preterm infants. And so this was 1978. Well, there's only been, aside from this, 2 other randomized controlled trials, and they're all very small trials. We've only had 3. That's it. There's nothing more. If you look at all the literature, and I'll show you what these studies did, but this is the first one that was done. So going in detail on this study, the null hypothesis for them was that there was no difference in duration until successful weaning from mechanical ventilation and endotracheal intubation, whether symptomatic infants with PDA are managed according to medical management or to surgical care protocol. Primary outcome, number of days between study entry and final successful extubation was the variable chosen to test this hypothesis. So the way they did their sample size, they based it on a short-term outcome, not a long-term outcome. And so what they were looking at, of course, decreased the amount of sample size that they needed. But it really didn't go and answer the questions that we really wanted to know about this, which was our focus on something like PDA. But this is how they designed this trial. Preterm infants less or equal to 1,500 grams with symptomatic PDA, and randomized medical management for congestive heart failure and pulmonary edema. They had to have that. And at 1 week of age, after having this management, if there was a large left to right shunt on ventilatory support, then they were randomized to medical management, continued medical management, or surgical closure. And then they were followed post-operatively. And this group, surgical ligation if they went into refractory congestive heart failure, and then medical management if they didn't have that. So there were some babies that fell into either of those groups. The methods there, their exclusion criteria were pulmonary infection, severe PIE, sepsis, meningitis, IVH. If an infant's ventilatory status appeared to be improving, study entry was delayed until the attempt to remove the ET2 proved unsuccessful. In the absence of sepsis, NEC did not preclude study entry after fluid balance had been restored. If medical management failed before consideration for study entry, the ductus was immediately ligated and the babies were excluded from the study. Their diagnosis of symptomatic PDA at that time, clinical evidence of large left-to-right shunt, cardiac failure requiring digitalis, a heart rate greater than 150, hyperactive precordium, gallop, collapsing pulses, a characteristic murmur, which would be that prolonged murmur that we were talking about before. Cardiomegaly on chest X-ray, and these were the other criteria that they had to say that it was a symptomatic PDA. They used a lot of criteria there. Post-operative, then, so they describe how they took care of the ones that they took to surgery and levels of tolerance of management on mechanical ventilation. And then they presented their results. But you can see that there were only 15 babies on one group and 10 on the other. And so it was a single center study at that time, and basically they were similar, the groups. The numbers were very small. But from their results, duration of ventilatory dependence following study entry was less for the surgical group than to the medical management. All the outcomes that they found were of bad outcomes that they looked at were more prominent in the medical management. And so their conclusion from this study was that we should be ligating all those babies that have symptomatic PDA. But again, it was a very small study, and this was outcomes of survivors after study entry, and you see the numbers here for infection, for BPD, were all bigger, but they were not statistically significant. And then came indomethacin, and we're in 1978. And so a new type of therapy, and Dr. Merritt and his group presented this paper in Journal of Pediatrics, and the possibility of using indomethacin to close that. And in contrast to that, you have the Cochrane looking in 2003 at indomethacin prophylaxis for asymptomatic PDA in preterm infants. Studies that have been done with this medication. The second randomized trial was from Gertseni, and that trial basically compared PDA ligation in symptomatic babies with PDA versus indomethacin. Of a small trial, and they didn't find any difference in BPD. What they did find was a decrease in necrotizing enterocolitis. So very consistent with Dr. Cotton's paper. Those two trials, by ligating the ductus, they had decreased necrotizing enterocolitis. And the third study that was done, I'll talk to you about that study. I'm going to jump this because this is pretty much talking about indomethacin. They did a systematic review looking at that, and these, you can just read over that, the conclusions from that. Yes, indomethacin could be very, very useful for closing the ductus, and it might have some advantages over PDA ligation, and so we began the era of using indomethacin and trying to avoid PDA ligations after this study. Then the issue came with a study that was done for prophylactic ligation, and that means babies that did not have respiratory distress were randomized to ligating the ductus, and then the other group would only be ligated if they developed symptoms. This was in less than 1,000-gram babies, only less than 1,000-gram babies. And so they had less than 1,000-gram babies, and so if they were born, ligation. First day. Yeah. First day of life. They were born, and they were ligated.
So
and then...
When you say prophylactic, was it with or without RDS, or with or without it? I thought it was basically babies who you couldn't diagnose clinically. They had echocardiogram.
It was babies born less than 1,000 grams ligation, and the control group was they would only get ligation if they had a symptomatic PDA. And so those were the two groups. And that was very interesting. So many people have analyzed this randomized trial. And this is a study by an author by the name of Cassidy. I'll show you the reference. But this was analyzed by this group here, but there was Dr. Kleiman went back and looked at this paper. Everybody's very interested in that paper because they wanted to show that if you ligated prophylactically a ductus, could you decrease or increase BPD? because that would be like the ideal. You don't have a ductus anymore, so you have to have some effect long term. So they did that. But what they're saying here is basically prophylactic surgical ligation of PDA resulted in a statistically significant reduction of severe stage 2 or 3 necrotizing enterocolitis. So that's the third study, randomized control study, that shows that you can decrease necrotizing enterocolitis with PDA ligation. But that's not the reason why we do the PDA ligation. But there was no difference when it came to BPD, IVH, ROP. Again, this is the paper by Cassidy, and so Dr. Kleiman took this paper and reevaluated and just published another paper on that, looking at that data. And but the thing is that at that time when they did this study, it was before we started to use surfactant. We're talking about 1989, this paper. And the definition for chronic lung disease was one that it's 28 days on oxygen. Yes, greater than 28 days on oxygen. And so he went back and tried to use the definition that we use now at 36 weeks post-conceptional age, being on oxygen. And he tries to show that being ligated prophylactically increases BPD. The problem with that is that we're trying to use definitions with different babies in different time periods. And so that's even more concerning. You can't do that because, again, it was a different time and different patients. But this is that third study that I'm talking to you about, and one of the most controversial studies because it was truly a prophylactic versus what we would call a placebo study. So now I'm going to go back to 1989 when we started to do this study at University of Miami. And this is why simple questions are important. And Dr. Bancalari came to me and said, you know, I'm seeing that babies that are less than 1,000 grams, there are some babies that are born with severe respiratory distress. And then there are some babies that are born without any respiratory distress. But I'm seeing that these babies are still getting chronic lung disease. And so that was the question I had to answer. And so we did this prospective cohort study to try to understand that. And so here's just how this was classified. So we classified them into low-risk babies and high-risk. This is a cohort of the whole study. It's not all the babies in the study. But we did a graph for that. We wanted to separate those babies into two distinct groups. And so these were the babies that were sick at the beginning with severe RDS, were high concentrations of oxygen, and they stayed dependent on oxygen and developed chronic lung disease. And here we have that definition, greater than 28 days. That's why you see the 30. That's the old definition of BPD at that time. And then we had a group of babies that were born on room air. And we have here 26 babies like that in 1989. And these babies were doing very good, 5 days, everything good, and then suddenly their oxygen requirements started to go up, and then suddenly they behaved just the same as the babies that had respiratory distress. Until that time, we believed that only babies with respiratory distress, severe respiratory distress, developed chronic lung disease. And we were seeing this group of babies. And this is a very interesting group because this group, 10 years, 15 years later, now everybody's talking about the new BPD, but there's no new BPD. It's always been there. We just didn't see it, or we didn't classify it, we didn't understand it. But it was there already because we had these babies that were being born now at 25, 26, 27 weeks. Those are the babies that we were already taking care of in 1989. And it was just, this study was going on just when the surfactant came in. So surfactant hit the middle of this study, and we were able to see the difference before and after surfactant in some of these babies. And so this is a graph of this. You can't see it very much, the FiO2. And this is just one baby where the baby is born on room air, and then suddenly you have something happened here to this baby. Oxygen requirement went up significantly, and then it started to go down, but never went back to baseline, and the baby had, at 60 days, oxygen dependency in chronic lung disease. That's the group of babies we were interested in finding out what was going on with them. And this is a summary of, in the low-risk babies, 48 babies, yes, what we started to find out. And when I brought this information to Dr. Bancalari, he said, I don't like that information. You have to go back again, and I don't believe it. I was going to presented at the SPR, and he didn't let me go to the SPR. He said, you can't go. We're not going to compromise my reputation with that information. And so I said, okay, back to the drawing board now. Because what I had found, I told them, they had done all these predictive studies, what can predict BPD. And PDA had been included in all the predictors, but the predictors were taken within the first 24 or 48 hours. And then they did all these models to try to say, oh, this baby's going to have chronic lung disease. And in that, he said, no, PDA is not really important. It is there, but it's not very significant. So, but I was telling him, well, it's not that early PDA. It's something that's happening after the second week of life. And this is what we're finding in this study, that PDA was reopening here day 16 on average. These are averages for those 48 babies. And that on average, 5 days prior to the opening of the PDA, there was a positive blood culture. So sepsis was reopening the PDA later, and then you treated those babies with indomethacin, and those babies did not respond to indomethacin. And so you had to wait to treat the infection and then close the ductus. Some of those babies, we were having more fungal infections at that time, Candida. Those ductuses, you couldn't close them for 30 days. You had to treat them for 21 days to take the fungus out, and then they were taken to surgery. So they spent longer periods where their ductuses were open. But infection was highly correlated with late onset ductus, and that's what this basically shows. Incidence of late PDA, we started to call it with a different name, but you can see here, this is infection for these and no infection, no infection, no infection, no infection. For all the different categories of birth weight, and here is a summary. If you had an infection, yes, the incidence of late PDA was significantly high, 24 out of 34. And when you didn't have an infection, it was 9 out of 46. So infection was a culprit. And so we said, oh, infection, increase in cytokines, opening of the ductus, more prostaglandins. We got an explanation for why this is happening. And then we looked at the association, the odds ratio for these babies developing chronic lung disease. And basically what this shows, if you had an early PDA, it was 2.8 times higher, the risk of developing chronic lung disease. If you had a late PDA, it was 21 times higher, the possibility of you having chronic lung disease. So the odds ratio jumped significantly. But when you looked at it in association or without association to PDA, if you had a PDA not related to sepsis, that means that it didn't occur within 5 days of the ductus opening, and then it would only be 4.5 times higher, the probability of having BPD. But if you had a PDA that was related to sepsis, it was 48 times higher the risk of developing PDA. And then we also were able to follow, though, because it was prospective, we were able to determine that the duration of PDA, of symptomatic PDA per week, there was a per week increment. And so for every week that you left the ductus open, the risk went up by 3.5 odds ratio. So the next one would be 7. Another week, and then it would be 10.5, and it would keep on going up exponentially as you left the PDA open. So we did find that there was a significant correlation, this, of course, with prospective data. And then we went on to, and I'll jump that because that's the summary of what this, we went on to do another study where we started to do echoes on these babies every day to follow what was going on with the ductus. And we started to get cytokine levels and to TNF and other cytokines to be able to see if there was a correlation between the elevation of oxygen dependency, the opening of the ductus, and having increased cytokines. We also learned there that many of the ultrasounds that we did, there were PDAs in babies that were looking great, not having any problems, but the PDA was there, and it was mild to moderate shunts, but the babies weren't doing anything. We didn't even hear murmurs on those babies, but we saw the PDAs there. So we confirmed what other people had found in the past, that you don't always hear a murmur. Again, this is so this basically summarizes. Let me see if so the questions. Oh, let me see. I went back to. Okay. So what we were able to show that there was a correlation between infection, and PDA. And that the longer you left the PDA, the more you had chronic lung disease. If the PDA stayed open, even without infection, there still was a higher risk of chronic lung disease. But we did an experiment just recently. I have a colleague of mine that does, Dr. Reese-Clark, that does, Jeff Reese, that does, his research is only PDA. And so he looked at our data and he said, I want to do a study in mice. And this is not published yet. But the data there was very interesting because he said, well, I can take the mice and he can dissect the ductus and he can bathe the ductus with whatever you needed to do. And he started to put cytokines to see how the ductus responded to. And he took all the cytokines that we measured in that second prospective study, and they did show that there was a dilatation of the ductus. But it was not very, very significant. And then we said, well, what else did we do for these babies? Well, we put them on antibiotics. So he put a bathing with ampicillin, and there was no change in the ductus in the dilatation. And then he put the bath, gentamicin, and the ductus went. And so gentamicin itself, when you administer to a preterm infant, based on that, and I saw that information with him, this is going to be a published paper, but gentamicin administration to premature infants is a potent dilator of the PDA. And so he's trying to put all this paper together.
About that.
Yes. Yes.
What do we have to do about that?
Huh?
What do we have to do about that?
Well, that's information that I'm putting out there because we don't know at this point. Yes, I think that his last name is Reese, R-E-E-S-E, Jeff Reese, and you'll see that paper coming out soon. But that's something that you need to add, that there are other things that make your ductus dilate. So yes, infection might be it, but maybe the effect is what we're doing with our antibiotics. Gentamicin might be doing it. So we've run out of time, but these are of the conclusions, that we have with respect to the PDA. I think that at the present time, there's so much uncertainty, and I think that we need to look at that balance to get down to the middle and try to figure out what we should do with ductus, but we don't have very good objective information. And so based on that, what does that tell us? If you don't have information, then we should all reach equipoise and say we don't know. And we do not recommend not doing or doing because there's nothing to support treatment A or treatment B. What we need to do is good research, and we have to do it in multi-center trials. We can't do it in a single center trial. So we do need to focus our attention on trying to design the appropriate trial. Some people say we can't do this trial anymore. Of course we need to do it. We can't continue to follow this uncertainty with respect to something that's very frequent and can produce a lot of morbidity. But we need to be objective and move away from opinion. Okay, that's it. Questions? Yes.
Dr. Seri says when you are having severe resistant hypertension, you should close everything.
When you're having significant
Hypertension, resistant one, not responding to treatment. Dr. Seri says.
Well, from what I've been able to do, reviewing the literature and what we've done, one of the things that we try to do is include our cardiologist in that decision. And the question that we ask our cardiologists in a baby that is a symptomatic PDA and you're treating the baby with restrictive, many have hypotension, so you have them on dopamine or dobutamine, many of these babies, and they're not responding and they're on high oxygen response. They'll look at I ask them for the echo and they ask them, tell me if you're left atrial enlargement, if you have left ventricular evidence of strain, and if they tell you that there is left, that means that there's overflow to the left ventricle, then that's a criteria that they would agree with us, yes, in this case we should ligate the baby. We don't usually do it solely on hypotension, but hypotension, if it's a reflection of severe congestive heart failure, and you're not being able to correct it, definitely the cardiologist would agree with you that you have to ligate those ducts. But we try to individualize it for each baby. I would not let a baby under those circumstances stay on just medical management. But again, that is an opinion based on some experience, but it's not objective information. So again, I can't give you a truthful answer based on the sparsity of the information there to answer that question.
And how easy can you diagnose a heart failure in extreme for baby? It's easy.
In a what?
And what is the diagnosis of heart failure in extremely natural baby? How that easy?
Well, you have, when you have the bounding pulses, the hyperactive recording, but I think the more objective is looking at the echocardiogram and being able to look, and they will tell you there is left atrial enlargement here, and there's left ventricular failure. So this baby is in congestive heart failure, and if you're not doing well with your medications, then that would be the baby that would tend to ligate. But we use our cardiologists to make that decision.
I listen to them many times that they say it's very difficult to diagnose left ventricular failure and heart failure in extremely natural baby. It's not easy.
It's not easy. It's not easy, and it's
There's
still...
no, they don't have science for that. They
Right.
can diagnose in indirect way, not indirect way.
I agree. So it is still difficult in 1966 to do that. Today it's still not exact. If it was exact, and we would use just those criteria, but it is not as exact. Yes?
And when a doctor reopens for the infection, when do you start treating the ductus? Is there a chance that it's closed spontaneously, or at what time would you consider closing it?
So,
Again, with another course of medicine, or
yes.
always struggle with it?
We struggle with that. So it all depends on how premature your baby is. Because the data that I showed you from the 1960s, again, were bigger babies. Now you have the small babies, and the smaller the babies are, the less possibility that they're going to close. Well, let's suppose that in a 24, 25-week it closed and then suddenly it's reopened. Our experience that if it reopened in the second week of life, the likelihood that it's going to close on its own is low, because we had more intrametricine failures with those babies. And so if the baby is not in congestive heart failure, you might be able to observe the baby. But if the baby is in congestive heart rate, on a ventilator, on high oxygen requirement, then the most probable what I would be doing would be ligating, based on the information that I've learned in the process of working with this issue of PDA. But you will always have less success if it's a late opening of the ductus. And if there's an infection, yes, and even when you go and send a baby for PDA ligation, we get blood cultures on those babies, and we get C-reactive proteins, because another thing is that some babies, you don't think that they have an infection, they don't look septic, their ductus is open, and they might be very sick. They send them to surgery, and then they find out that the babies were infected. And sometimes it's when they get the infection in surgery, but other times is that we send them with the infection, and then they have more poor prognosis. The bad outcome that they're saying with the surgeries, with PDAs, is happening in great part because we're sending these babies at a very, very bad time when they're really having severe chronic lung disease. So of course, your outcome is not going to be good. So it's all a self-fulfilling prophecy that PDA ligation is going to make them worse neurologically, because already they have severe chronic lung disease and high oxygen exposure. So a lot of confounding variables there. Okay, we're going to cut this. We can talk more about that. So we want to get that other talk